Those are some of the areas, and I really do feel that the education and the stigma are probably the biggest walls we run into.
Michael, you wanted to make a comment?
Yes, just to follow up, I think a second wall that people with schizophrenia face are the current short hospital stays, which are about on the average of only 2 weeks these days. But back in maybe 10 years ago when I was first diagnosed, I was in inpatient care unit, and I was there for about, maybe 8 weeks, maybe even 10 weeks. And I found that very, very therapeutic. But subsequent stays in hospital years after that, they were only like about 2 weeks. And I don't think 2 weeks is sufficient enough.
Dr. Ismail, would you like to comment on that? And I'm also interested to know what your opinion is of the sort of average level of expertise in the emergency rooms.
I would agree with Michael in that it does appear that hospital stays are getting shorter. Now, this depends on the venue. If we're dealing with a general hospital, they're certainly shorter than they are in a psychiatric facility, and I think that's understandable. In part, that does relate to the level of expertise inherent in those two different systems. And it's actually unfortunate that they're separate, because one comment I wanted to add earlier on is that we've described very well barriers to accessing psychiatric treatment and the government decreasing wait times for MRIs and hip replacements, etc. When you take someone with a psychiatric illness, they have very poor access to those medical treatments, and those are also fundamental to their health and well-being. To separate out brain and body, I think, is in part artificial, and I think the public also needs to really know this, and that will decrease stigma. So in terms of level of expertise, that really comes from in part a training experience. In current family medicine residencies, for example, there's only 1 month of psychiatry training. And if someone goes into emergency medicine, either they're 1 to 3 more years of training beyond that, they get varying amounts of psychiatry. The psychiatric support from a crisis team in the emergency room really improves the expertise for that certain center, and the relationships between the crisis team and the emergency medicine team are crucial to ensuring that that expertise is at a high level.
Lani?
Sorry, I just wanted to add, and I think Dr. Ishmael mentioned this earlier too, when it comes to triage. That's a huge issue in the ER, and I think the difficulty is that psychiatric symptoms aren't as tangible, they're not as visible. If someone comes in on a stretcher and they're bleeding, it's much easier to determine sort of the level of acuity of the symptoms and the type of care that the person needs. But it's not as easy with some of the psychiatric symptoms, and I think you're absolutely right, is that it's education is really needed, and I think a certain amount of sensitivity training as well. I think from what I've heard from many people is that not only are you denied care when you have a serious mental illness, but you're not treated with the same kind of compassion as someone who has sort of a physical illness and has those types of symptoms. And I think that's a real tragedy in our system that's happening.
Mm-hmm. Peter?
Just a thought came to mind as we're having our discussion. We're talking about barriers and access to treatment and how it could all be improved. But I think from my perspective, one thing that's important to keep an eye on is that we have to work right now within the system that's there. This is a fairly large ship to try to turn or try to improve, although we can move towards those things, I don't think that we should be thinking exclusively that that's the target. We want to improve the system, yes. We want to work with service providers. As family members, we want to work with service providers to improve the system. But we also need to understand how to operate within the system as it stands right now. And as family members, if we can educate ourselves on how to maneuver through the system, how to cooperate with service providers, and if they in turn will work with us on those things, then we can begin to have more effective services right now, working towards the ultimate model that we want. So, I mean, that's one perspective on it. And in hand with that, and I just really want to stress this because I truly believe it, I think it needs to be a cooperative effort. Family members need to understand what the system is able to provide with them now. They need to understand how to advocate effectively to improve the system going forward. And we would like to see service providers at the table with us discussing those things rather than having a confrontational conversation about it. That's not the intention. I personally think we'll be much more effective if we all look at it and say, okay, look, we want to provide the best service possible, and we as family members want to provide or want to get the best service possible. So how do we do that?
Dr. Ismail?
I'd like to add to that in that I agree with everything Peter has said so far, and it saddens me that access for some families comes through the forensic or the justice system as opposed to the mental health system, which in its own right is set up in such a confrontational fashion that it leads to a lot of suffering. And one of my most common experiences with family members is their frustration that they can't get access for their loved one because of all those, once again, those consent and capacity issues. And it's not until there is a legal aspect to this, then through the justice system, they can get more access to care. And I'll give the other example. I mean, that this is in part, it appears more of an Ontario phenomenon than elsewhere in the country. I also work in Alberta and did my training there. And it does appear that through the mental health system, there is more access that way and a higher level of collaboration than there appears to be here. So in the short term, we need to certainly have the education and the awareness anti-stigma programs that Peter's talked about. That's something we can do over the short term collaboratively. But in order to really turn that boat, we also need to involve other levels of advocacy to really address some of those more systemic fundamental issues.
And Vani, did you have a comment?
Mm-hmm. I think it's really important that the issue of accessing treatment through the criminal justice system has been brought up because, when we talk about criminalization, that's what we're talking about is people accessing mental health services through the justice system because the mental health system has failed them. And, we really believe that access to treatment and criminalization go hand in hand. And part of the reason why people with mental illness are becoming criminalized is because they aren't able to access treatment through the traditional pathways. And I think, we as society and the system need to take responsibility for that we are not providing adequate care. We're not ensuring prevention. And as a result, people are left, without the service that they need. Their symptoms are becoming exacerbated and they're coming into contact with the law. And it's, it's not only unfortunate that that's happening for the individual, but it's quite costly to the system as well, and to taxpayers. It's, to keep somebody in jail for a day is very, very expensive. So I think for several reasons we really need to turn things around. And I think, Peter talked about this ship and turning the ship around. And I was just at a conference on the criminal justice system, and one of the speakers said, we